Wait, all the residents and all the residents.
People sometimes end up sitting on the floor.
You don't need to.
Oh, good.
My hammer pants are warm.
So one day they'll actually put something from the ceiling. If today's not that day.
That's okay. Is this attached to anything?
It's actually this is all for the
Oh, okay. It's all okay.
this side. Whenever you're ready.
I do think there's going to be
People can.
sure. I'm not in a rush. You guys falling asleep already?
No. We are awake.
Nah, we just got here.
Yeah.
Ooh.
Clearly you need more or let's say not something that's going to be in your anytime soon. Yeah, I didn't know if you guys had that readily available meeting somewhere.
Always helpful.
We're kind of still reviewing it, so if there's any changes to it.
The flag to the solar law conversion. Solar law, I see it's 72 hours after on the hyperopsit.
I have a little. She's here. It was really long though. Sometimes like sit by the bench, I'll just like play with it. Like I'll just
Do you get like one random neck hair?
one random hair. Yeah.
How long do you give it to?
Maybe it's a Tierney washout.
Tierney's got one. So
Usually probably about one.
Yeah,
it's
it's
like
like weird.
it feels like it's like forced.
You can always check the level and see.
It's like an eyebrow hair. Sometimes I get it in the
I don't get that.
That's less often. It's more often like right here.
Do you still overlap
The
that
other day.
with at any point, or does it just
Like,
your solar law?
usually just hey, some.
Yeah, and I usually don't feel it until it's like this long, and I'm like, what?
Try to, once we get into that category of risk for mom, then try to.
I'm cold, but I like can't stop myself from like sucking on the ice.
Yes. 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 We're also just making sure we're not going to make them on going to PT.
That's what you're looking for.
Well, either I'm just lighter. You can see it.
I'm transparent.
Me too.
Yes, I remember your face. There's a wide variety.
No, my veins are big today. I must not be inside. It was the end of the bottle.
Yeah, you have to. You have to. You can't stop.
You're like, I can't sleep.
No, you have to.
This will augment significantly.
Do you want me to put it on this either time?
There has to be someone right about here.
Stand the whole lecture and just hold.
No, it'll get very shaky. Your poor arms will fall off.
It must be cradled. Huh?
It must be cradled in love.
Should I go ahead
get that.
Okay. I can introduce Okay.
I'd like to welcome Dr. Haynes, who's come from the Department of Pediatric Cardiology. And thank you, Dr. Sharkey, for coming as well. I know it's titled as Dr. Sharkey's lecture, and it's a good last minute.
Bait
I
and switch.
deferred.
Deferred is always welcome, but glad to have you here, as always, for all our pediatric talks and informing us more about fetal cardiac arrhythmias. And thank you again for allowing the fellows to work with everybody at Glennon, and we find this is a great opportunity for us to learn. And thank you. I think she's going to talk to us about fetal arrhythmias. She just recently started back in last year, about a year ago, at Glennon, and hopefully will work in some time for us if you don't hire any new pediatric fellows.
Well, hopefully they won't boot me out even if they do hire new pediatric fellows. Okay, so again, I'm Susan Haynes. It's nice to meet you guys. I've seen a few of you previously when I've come for this conference. So, So my goal today is really talk about the methods of diagnosis of fetal management, so the different techniques that we can use, the types of fetal arrhythmias, how we manage those, the goals of the treatment, and the risks of those treatments, and then suggested maternal monitoring with initiation of medication. Thank you. So just as a brief review here, I'd like to just show you the cardiac conduction system so we can all remember what that looks like. I don't know about you guys, but sometimes I get really focused on my one area and forget other things. So just remembering that the sinoatrial node lives in the right atrium here and depolarizes first, which carries the electrical impulses throughout the atria. And then that coalesces in the atrioventricular node, which then gives rise to the bundle of His, the right and the left bundle branches, and that thus depolarizing the ventricles. So for methods of diagnosis of fetal arrhythmias, there's a couple of things. Of course, you're all familiar with doing just Doppler auscultation of the fetal heart rate in the clinic, and that's a very good screen for does it fall within the normal range or does it fall out of the normal range. Unfortunately, that doesn't really help you determine what the atrial rate is. So that auscultation, remember, will give you the ventricular rate. Doesn't tell you what the atria are doing, and doesn't give you an idea of the origin of the arrhythmia either. So the next step would be M mode, and that really requires a beautiful picture with a nice orientation of the heart chamber so that you can get the sample volume through both an atrium and a ventricle. It does help you to evaluate the rhythm without clips, and I don't know how many of you guys are storing moving clips when you're scanning. Previously that tended not to be done, so that helps to see some correlation of the atrial and ventricular activity. You can add color flow mapping to delineate the inflow and the outflow if you get a great M mode. The next step would be pulse Doppler. And this also allows for evaluation of the rhythm without clips. And it's helpful, I find, if you can sample, I'll show you that in a minute, position the sample volume in the inflow and the outflow of the left ventricle. This is harder to accomplish in the right ventricle, so that's really one of those limitations there. And then 2D imaging, which of course you all start with when you're scanning, but don't often necessarily save. So this requires clips, not still frames. But you can really visualize the relative atrial and the ventricular rates if you can get a nice picture, and sometimes you can almost see it more easily just by 2D rather than trying to capture it with the M mode and the pulse Doppler and all of those things. And color flow mapping, again, can help you see the inflow and the outflow relationships there. Fetal electrocardiograms are not widely performed, but that is something that is being done in some centers. Does have some benefit. The PR interval has been shown to be more reliable in a fetal ECG than our mechanical PR interval that we do by Doppler. But again, it's all a risk, benefit, and availability sort of balance. So again, we talked about the M mode sampling here. You have to have a nice picture and be able to position your sample volume through an atrium and ventricle. So you see here Here is your spine back here. And so this would be your left atrium here, the most posterior chamber of the heart. So this is your right atrium. So you can see here, this sample volume is oriented through the right atrium and the left ventricle here so that you can see both atrial and ventricular activity. And in this chamber, so remembering, you can see this tiny little reference image up here, right atrium, so your atrial activity is here on the top, and your ventricular activity is here on the bottom. So this dark space here is the left ventricle, and this one is the right atrium. So here you can see really there's pretty much a one-to-one atrial to ventricular activity. So atrial, ventricular. So this is sinus rhythm. You can see that the heart rate is 141 beats per minute, which we would know would be a normal heart rate for a fetus. So another view of this, so now we've this is a different baby, we've kind of switched orientations again. Your spine is here, so this is your left atrium, making this your right atrium. This is your left ventricle, which they've nicely labeled for us. With the sample volume here through this axis, you would get again your atria on the top, your right atrium, and then your left ventricle on the bottom. And you can see nicely with these arrows here that your atria is moving faster than your ventricles here. So this is consistent with atrial flutter with 2-to-1 conduction. There's 2 atrial contractions for every ventricular contraction that you see. So again, you see this is now, you guys probably get these perfect views every time that you scan a baby. I don't always. But you can see how this can be very helpful if you get a nice clean image. If baby is rolling and moving and things are a little fuzzy, it can be hard to tell, okay, do we have these perfect ventricular contractions or not? This is an example of not quite as perfect a picture here, but again, you can still figure out, again, right atrium up top, left ventricle down here. So your atrial activity is in the top of the M mode here. You can see we're going along regularly. We have 1-to-1 atrial and ventricular conduction. And then we see this atrial beat, and then we see an early atrial contraction here, or a premature atrial contraction, followed by a pause in our normal ventricular rate. So this is a blocked premature atrial contraction, which is one of the most common arrhythmias that we see, and fortunately is one of the most benign. So with M mode with color, now this is really upping the ante, right? We not only have to have a perfect M mode picture, but we also need to get good color fills so we can capture those. If you sample again through the inflow and outflow tracks, so this is the red flow here is the ventricular inflow. So this is the ventricle here running along the top, and then you have aorta here, and then you have atria here. So what we're seeing here is the red is the ventricular inflow, so this is diastole, and then the blue is the aortic outflow here. So just in case you're having a hard time lining up all the squiggles on the M mode, sometimes it's easier to just say, okay, red, blue, red, blue, red, blue. That looks like sinus. Now, unfortunately, I don't have a good sample of this where there's a pause, but of course if we were going to see that, say a blocked PAC where we didn't have the normal ventricular activation, we would see an absence of this blue aortic outflow here when we had a pause for that ventricular systole. So Doppler, here's a little 2D or a little diagram of our ideal positioning of the Doppler for sampling through the inflow and the outflow of the left ventricle. So remember that in the normal cardiac morphology, there is mitral aortic continuity. Thus, the aortic valve and the mitral valve are in continuity with each other. And that allows us to position the Doppler signal just in between those two so that we're able to sample the diastolic filling of the ventricle and the systolic outflow of the ventricle, and that gets us both of those pieces of Doppler data. And this you can store, is best stored with just a single clip once you get the perfect image capturing your arrhythmia. The other thing that's helpful with this view is that you can measure the mechanical PR interval. Now a little bit we'll talk about how useful this is sometimes in the management of kids who have congenital heart block and things like that, complete heart block, or who we're worried about. But regardless, remembering that, since we don't have a fetal ECG readily available, we are using the byproduct of the electrical PR interval and measuring our mechanical PR interval. Thus, what we're measuring is the onset of the atrial contraction, which gives us our, which gives us our A wave. So remembering that this is our E wave, this is our A wave of inflow of our blood into the ventricles. So we have passive filling and then active filling. The active filling is representative of the atrial contraction. So remembering that the P wave is really the onset of atrial contraction, thus the inflow from that atrial contraction is the beginning of our P wave. And then our R is the beginning of our aortic outflow. So here we see, if we're measuring, you guys probably can't see that, can you? But if you measure from the beginning of your A wave to the beginning of your outflow, that will give you your PR interval. Typically, we think that if it's above 140 or 150, then that would be considered first-degree heart block. More often, it's around 100 to 120. You can see this. Now, what I just showed you is, I think, one of the easiest images for me to reliably capture, and one of the easiest ways for me to kind of think about the the hemodynamics that give me that Doppler wave. Now, other people will, and I don't know, Angela, how often you do this, position your Doppler and do retrograde venous waves and outflow. I don't know if you feel like that's easier for you to find. Do you typically do the other one as well? Okay, but regardless, remembering, if you think back to your CVP tracing, how you have the hump that goes with your atrial contraction when there's a little bit of reversal in your venous system, you can see this reversal of the venous, this is your atrial contraction and the reversal in the venous system. Up top here is the SVC flow, normally prograde, going towards the heart. And then you have this little retrograde kick when the atria contracts. And then here they've captured the outflow again. So you could measure the onset of this retrograde atrial wave to your outflow, and that would in theory be the same measurement that you're getting with the LVOT and the inflow. Regardless, I say, get the picture that you can get reliably and make that measurement. But here in this view, you can see initially that this is prolonged to start. Now the measurement's not up here, but take my word for it. And then what you can see is that there is an abnormal conduction. The relationship of the atrial contraction to the outflow changes, so that initially you're having conduction and then you don't have conduction and then you have conduction. Does that sound like anything you've ever heard of before? And then eventually you have complete dissociation of the atrial waves to the outflow, so that would be complete heart block. Okay, so this is a progression of, now again, most people will say that it's hard to see prolonged PR interval that then progresses to complete heart block. Often we kind of miss that progression because sometimes it happens very quickly. But this is an example of that.
So Susan, the one time I do use that is if you have a fetus that has high drops and you're trying to assess the cardiac diastolic compliance, because you'll get augmentation of that A wave in the IVC.
Good point. Yep. Which you would expect to see in this type of situation too with your heart blockage. Y'all stop me if you have any questions if I say something that doesn't make any sense. Okay.
Susan,
yes.
For obtaining tracings for the K index, are you placing your cursor at a similar place that you just showed for both inflow and outflow from the ventricle?
Yeah, I think that's usually, don't you think, for Tay index?
Oh, yeah.
Inflow, outflow there. Yeah. Okay. So then 2D, so this is just a visual representation. Now, again, you guys always see this, but sometimes we're in the situation where you have the mom here, you don't really want her to go anywhere, but you want to know what the rhythm is, or want at least confirmation. You guys have a great idea of what's going on. You just want us to say, yeah, we agree. This is why a moving clip that's stored that we can see is useful. Okay, well, we all recognize that's really fast, right? Okay, so again, even though this isn't a super clear image, right, we say, okay, so what we need to know here is the heart rate, right? There's definitely some tachycardia going on here, but this can be very helpful and demonstrative. Okay, so fetal ECG, we talked about that, is not widely available. It's a signal averaged ECG, so that's kind of, you know, taking all of the data that you can get and averaging that together. It's a little more challenging to perform. You don't always get great P waves, which of course in arrhythmias we really like to see where the P waves are. It kind of helps us significantly. It's not readily available, but if it is available, if you live in an area where you can easily get that, it can be useful to most likely confirm what you've seen by ultrasound. Okay, so treatment considerations. You know, this says here, hospital medical errors kill 98,000 Americans each year. Okay, so we always want to be sure that what we're doing when we decide to intervene is indicated, and that we do it in the least risk possible to the mother and to the baby. And again, we all took that oath to do no harm. So there's always the potential for iatrogenic fetal or maternal proarrhythmia. Why is everybody pointing at you? You either say that all the time or...
We brought it up yesterday evening, so.
Okay. All right. So, you know, we're remembering that we're giving medications. You know, the medications that we use, if you look at this, and I didn't really provide you with a handout of this whole thing, but I provided you with kind of the nuts and the bolts of what in the situations where we give medications. These medications are dangerous, and we need to remember that. So they're fine when we use them appropriately, but we need to monitor and be sure that we're using them only when it's indicated. So there's always the potential for spontaneous improvement or resolution. That may not always happen, but that's when we do serial evaluations. And then there's the option, depending on the age of the gestational age of the baby, for delivery and then postnatal management, at which point we would at least be removing one of the people from the risk, that being the mother, if that's safe for the baby. Okay, so our treatment goals are really to restore sinus rhythm. That'd be ideal, right? If not, then control the heart rate, or improve or resolve the heart failure, and to postpone preterm delivery if it's appropriate to do so. So sometimes your success is not sinus rhythm, right? Sometimes you get less high drops, or your heart rate is a little bit slower, thus allowing more filling of the fetal heart. Or it's the baby's in SVT only 11 hours of the day instead of 22, right? And then failure is worsening of high drops or no improvement. So in general, thinking of fetal arrhythmias, we can kind of divide them into the bradycardias, the tachycardias, and then ectopies. So bradycardia we generally think of as less than 110 beats per minute. Some examples of that are congenital heart block, congenital long QT syndrome. Tachycardia is greater than 180, such as SVT or flutter. And then ectopy, really premature atrial, is probably the more common one that we see. We don't see lots of PVCs, and that's not quite as reassuring as PACs in the fetus. So for bradycardia, potential etiologies, if it's sinus bradycardia, you clearly see that it's one-to-one conduction. And then that's when you kind of need to do the screen for the general well-being of the baby, which you guys know way more about than I do. But in general, considerations for, is there acidosis or is there hypoxemia going on that's causing some bradycardia? Polysplenia or other complex heart disease. Sinus bradycardia can be a harbinger of sinus node dysfunction later on in the fetus with complex heart disease. And then long QT syndrome, which has really become widely recognized in the postnatal life and is screened for pretty commonly now, especially with athletes dying suddenly. That always brings things to the forefront. But we can even see that with fetuses, or the suggestion that there is long QT syndrome with fetuses. Now, we haven't figured out how to measure the QT interval very reliably in the fetus, but this, looking at the long QT postnatally, is something to keep in mind. So you can also have blocked premature atrial complex in a bigeminy pattern. So if you have one sinus beat, one PAC that's blocked, one sinus beat, one PAC that's blocked, you'll end up with a heart rate that can be even lower than 90s, usually around 70s, those babies end up being, which we recognize as benign. And then complete heart block with, most commonly the anti-SSA, anti-SSB antibodies. About 50% have that, and about 50% have complex congenital heart disease. Generally, if you have complex heart disease and bradycardia as a fetus, that's going to be a very difficult prognosis. Okay, so for bradycardia, when there's no structural heart disease, most often it's the maternal autoimmune disease. It's 1 in about 20,000. And about 50% of those mothers affected are asymptomatic, as you guys are probably very familiar with. And then for the maternal testing for the anti-SSA and anti-SSB antibodies, those been seen that mothers with a higher antibody titer have higher risk fetuses. And about 80% of those fetuses with mothers who have high titers will have some sort of cardiac impact. So we generally recommend that, and you guys I'm sure do this without us even knowing about it, frequent monitoring between 16 and 24 weeks gestation. Remembering that those same antibodies that can cause heart block can cause other things. So we're not just looking at the heart rate. It's not enough to bring mom in and lay a probe on her belly and listen. We need to look for myocardial dysfunction, so poor ventricular systolic function, endocardial fibroelastosis. You can see that sometimes even starting in the right atrium around the conduction system there. And then those can be harbingers of complete heart block. So in the mother that you're seeing myocardial dysfunction but not yet any changes in the conduction system, that's your possible intervention group that may be the one that you might have the most effect on. And remembering that these babies can also have rupture of the papillary muscles or chordal attachments later on in gestation, which would give you significant, probably mitral valve regurgitation, which could be very hemodynamically significant immediately after birth if that does happen. So we talked about measuring the PR interval. Again, 140 to 150 milliseconds is prolonged, is considered first-degree heart block. So the question is, does this identify the fetus who is at risk for progressing to complete heart block, or is this just a baby who's going to be born with first-degree heart block and is not going to be really significant? And are these the babies that should be treated with dexamethasone? So these are kind of questions to think about. I'm curious to hear your thoughts about this. Of course, this was a study that looked at as a prolonged PR interval. Does that predict progressive heart block in a baby? This was back in 2011, and this suggested that it did not predict progressive block at birth. Now there's many, many studies out there. So what do you guys think about this?
I don't think if you use it to determine treatment with Dex, I just don't know if the outcomes of dexamethasone have really been proven to be supportive. So.
Right. Yeah. So the question, if you find the fetus in complete heart block, I think most people will say, well, we've missed our window, right? So Dex at that point is probably not indicated. But what's your thought, Dr. Sharkey? Agreed. So we're still trying to find the exact best way to intervene with these children, I think.
Let me ask you a question. On a couple slides, it said monitoring at 16 weeks. Have you seen babies develop this at 16 weeks? I've never seen it.
Yeah, I haven't seen it.
I don't see everything, but
yeah.
But I've never had it.
Yeah.
Usually it happens later. Second, 16 to 20.
I think that's most
Not
of
a good outcome.
With just
Not a good outcome.
Without structural heart disease. Just simple, straightforward bottom.
Yes. And somebody can diagnose
A couple of cases from the East Coast have tried IVIG
yes.
in recurrent cases. So a mother
Mom
who had
has
an
already
infected baby in a prior pregnancy and surveillance in a subsequent pregnancy have tried to inhibit the maternal immune system.
And that's without even noticing any PR prolongation. It's a prophylactic measure.
Yes.
Right? And the same with plasmapheresis that they've done with some mothers as well. So yeah, I think that once the horse is out of the barn, then we're in trouble. I think we haven't necessarily identified the ideal time. Certainly those mothers who are at risk for recurrence will be watched much more closely.
And I think the other challenge for us is, we can drive up the cost of healthcare trying to monitor for this, but the actual impact that we have on changing the outcome is so limited that some of my colleagues recommend weekly monitoring with assessment of the PR interval. Well, what difference does that make other than making their healthcare more expensive, right? So I think that's our challenge really in our specialties, is trying to figure out what is the right timing. And those individuals involved in the PRIDE study, which you're going to talk about next, were adamant about their use of dexamethasone in the pregnancy, and lo and behold, I don't give a
Yeah, so they noticed there that in the PRIDE study, this was the PR interval and dexamethasone evaluation prospective study, was that prolonged PR was really uncommon. So we do measure it. I measure it in every baby I scan, but I don't know really if it makes any difference. It didn't precede any more advanced block, and that advanced block and complete block can occur within 1 week of a normal echocardiogram in which there was a normal PR. So they said, well, maybe we should look more for those echo bright areas, the EFE signs, tricuspid regurgitation, myocardial dysfunction as early signs rather than measuring the PR interval. So that is basically the recommendations from that study.
And I think from a postnatal management standpoint, a pacemaker isn't an insignificant intervention compared to a lot of other things we do. Pacemakers are no big deal, right? And you can live with a pacemaker for a really, really long time, with a generator change, and then ultimately you'll need lead changes as you grow and so forth. The challenge for these kids is the ones who have the myocardial dysfunction. Right. Those are the kids who do not do well long term. And so looking for that echogenic brightness in the heart is a skill set that we all need to acquire and attend to, because those are the fetuses probably, or the ones that we may want to think about intervention, such as IVIG or dexamethasone.
And I think,
so how often would you recommend looking for that in these cases with no prior affected child, just elevated titers?
When I can.
do you,
I see these ladies at most every month. And again, that's my approach, because I believe this data that shows we can't really make that much of a difference no matter how often we monitor them. And so you guys are seeing them, I know, I'm seeing them. I just feel like we don't have to monitor them that much more carefully. That doesn't mean that that would be the standard of my colleagues.
and would you say you would follow them in a month with the thought that their OB is seeing them more frequently than that?
Well, I think what I like to try and do is stagger visits rather than having us all see the same.
So you're not recommending that they see them once a month necessarily, but
Yeah.
We do rely heavily on you guys for interval changes there. I think what would be more interesting, well, not that this wasn't interesting, but as a next step, would be, because we know that there is a not insignificant percentage of these children who go on to have dilated cardiomyopathy, which is definitely going to be more pathologic than having a pacemaker for the rest of your life. So is there something some fetal intervention that decreases that risk that will put you down the transplant route? That would be a significant, change. Would be interesting to know.
So just to be clear, so there's no good data for dexamethasone in this setting.
Essentially, yeah.
Simple as
Yeah. I think
It's one
we
of
don't.
these, but it's one of these things, I'm sure, you've heard at meetings, you should try this stuff, it's the greatest thing since sliced bread, and then, by the way, the data doesn't support it. So we thought it was really good. So 1 year you'll hear, you should be doing this, and then 2 years later you'll hear, oh well, never mind.
And you'll hear all the bad things that it does to the mom and the baby. So.
And if you had a prior affected child in those rare cases and you found a prolonged PR interval, this benefit ratio, I mean, I think it would be worth trying, even though the data's not there when you just say all comers. So,
I guess, I mean, all of us have to practice the art of medicine, but we should practice the art based on the data that's available to us. And I think the step that we often shortchange is taking the time to look for the data to support what we're doing, rather than saying, well, I heard this 2 years ago when the study was going on. And, I also do Marfan syndrome. This is a perfect example of the lay press has said so much about a particular drug therapy, losartan, for this disorder, and it's going to cure the problem. And in fact, there is absolutely no data to support that unless you're a mouse, right? So we need to be careful to look at the data that's available and make those decisions.
Yeah.
Okay, so this is an example of complete heart block. So again, this is an M mode with the sample volume through the right atrium and right ventricle here. And you can see, really, there's no association between your atrial activity and your ventricular activity with this baby. Now, fortunately, the ventricular rate is quite nice, 111 beats per minute. So that's favorable from a heart rate standpoint, at least. So complete AV block, of course, they're higher risk if their ventricular rate is less than 150, if their atrial rate is less than 120. Better prognosis if their ventricular rate is greater than 60. So some advocate the treatment with terbutaline to reach that magic 60 number. What do you guys think about that?
Pluses and minuses.
Right. Okay, yeah. All right.
Residency of some of our MFMs use turbo pumps, so that was really good for a lot of ER consults for residency.
So it provides learning opportunities.
Yeah.
Okay.
Yeah.
Okay.
Another way to drive up the cost of healthcare.
Yeah. Okay. So depending on the heart rate and the high drop status, so now obviously this is a baby with severe high drops. You see the heart here in the middle of a bubble of fluid.
It's a nice
and really,
heart chamber view.
that is a beautiful, isn't it nice? Yeah, you can see the heart so well when it's suspended completely in fluid. I find that true. Yes. So this baby probably would do better out with a pacemaker than in, but maybe not. So yeah, you would have to drain a lot of fluid if you were going to be successful there.
Is there any treatment
For AV block?
besides terbutaline?
No, they've tried.
Using digoxin before to increase contract. Used to
I
years ago, I don't know.
Not if you already have heart
not
block.
with heart
though.
block. Yeah, that's one of their concerns with using DAGEs, causing heart block and progressing heart block.
There were some attempts at in utero cases, but
Right.
again, they were not.
There haven't been any reported survivors yet with that, so I call that a fail. So yeah, really, yeah, yes. Actually, I don't know if anyone's currently trying that right now. I think they were trying to develop a new lead. So really, our postnatal interventions, assuming we can get them to a deliverable gestational age, would be temporary pacing. So we can do a temporary venous catheter or a transesophageal pacing, which is not quite as successful with complete heart block. Isoproterenol infusion to increase the heart rate, and then ultimately implantation of a permanent epicardial pacemaker, which, as Dr. Sharkey alluded to, is a pretty straightforward procedure. More often in little babies, we have more problems finding room to put the generator than actually placing the leads. Is a pretty straightforward thing. So just
And actually,
healing.
the one exception I would say to that is a preterm baby. So,
Yeah, the smaller.
preterm babies have no fat, right? And we, or our surgical colleagues, really rely on being able to bury that pacemaker in the abdominal wall and have it heal in nicely because there's fat and there's good blood flow to that tissue. In a term baby, that tends to be true, but in a preterm baby, they have a lot more problems with erosion of their pacemaker pocket. So when you're thinking about, do we deliver this baby or do we wait? If the hemodynamic picture of the baby is stable, we would prefer to have a term baby always than a preterm baby.
Yes. Okay. So remembering with, why is this slow heart rate such a problem for a baby? And it's really because the fetal heart really can't adapt well to changes in preload and afterload. Remembering that a baby increases their cardiac output really not with stroke volume, but with heart rate. And that's part of the Frank-Starling curve mechanism that we learned way back. But increase in preload for a fetal heart does not increase cardiac output. It really only increases your end diastolic volume, your end diastolic pressures, and then you have decreased diastolic filling of your ventricles, and then your systemic venous pressure increases as a result of that, and that's your first more pronounced reverse flow with your atrial contractions. Okay, long QT syndrome. So I briefly mentioned this earlier. Often these fetuses will have sinus bradycardia, and occasionally you'll capture them in some intermittent concerning tachyarrhythmias. And there was a study done, this is back in 2001. They looked at 18 children born with long QT syndrome who were diagnosed postnatally. Retrospectively looked at their heart rates during the fetal period, and 71% of those babies had persistent sinus bradycardia. So that's a pretty high percentage there. So these are the babies, you don't really need to do anything differently with them while they're still a fetus. But what you can do is convey to the pediatrician or the nursery staff or wherever they're going, hey, this baby needs to be screened for long QT syndrome. And sometimes that, we don't know what those heart rates are at all during those office visits where they come in often, unless we're really, really good at Epic. I'm not quite that good. Then, that's a great communication to pass along to the family. What you don't really want to do is get an EKG on day of life 1, okay? Because every baby's QT interval looks long and looks funny, their ventricular repolarization looks strange when they're like a day or 2 old. So if the baby's stable, then you could maybe wait until they're a couple of weeks old, at least, to get that screening EKG. Definitely the family history is very important. So when you see that sinus bradycardia, you may want to ask, does anybody in your family have long QT syndrome or died suddenly and nobody knows why? Drowned, even though they're a good swimmer, or had a single car accident without any real explanation. Okay, so tachycardia, fetal heart rate greater than 180. Atrial tachyarrhythmias are much more common than ventricular tachyarrhythmias. Again, if you see those ventricular tachyarrhythmias, long QT syndrome needs to be pretty high on your list. So most of the tachycardia that we see will be SVT. About 15% will be flutter, and then there's a smattering of other arrhythmias that account for the rest of it. So SVT is 1-to-1 atrial conduction with abrupt onset and termination. The heart rate's usually around 200, 250, 300 or so. It may be paroxysmal or it may be incessant. And if you're seeing a high burden of SVT, then you're probably going to see high drops in about 30 to 60% of patients. It's usually an AV reentrant mechanism, so there's a little circuit that allows for the involvement with the atria and the ventricle with this reentrant mechanism to result in SVT. Sometimes it's AV nodal or permanent or persistent junctional reentry tachycardia. But here you can see in this end mode, very fast and 1-to-1 atrial to ventricular conductions. So this, don't squint, just look at your papers that I gave you guys for reference. And so there's SVT on one side and flutter on the other side of your paper. So currently we're looking at the SVT one. You'll notice that the first big divider is sustained versus not sustained. The differentiation in that is less than 12 hours in a 24-hour period or greater than 24 hours. If it is not sustained, you can monitor them. And if you're not able to, if mom's not able to come in for frequent monitoring, then inpatient hospitalization might be necessary. If it's really non-sustained and there's no high drops, then you just can continue to monitor them closely. If there is sustained, then the next differentiation is there high drops or not. No high drops, we usually start with digoxin. And then if there is high drops, then we usually bypass digoxin and move to flecainide, although flecainide can be considered a first-line therapy as well. And we typically would recommend checking the maternal level about 72 hours after the first dose and getting daily maternal ECGs. If your flecainide is not successful, then you can consider changing to sotalol rather than adding it. It can be helpful if you're getting to the sotalol point. So remember we talked about first do no harm. Sotalol is a pro-arrhythmic drug for the mom and for the fetus. And so sometimes it can be helpful to have your friendly adult cardiologist on board for helpful management with the mom. So I don't know how readily, they're pretty readily
available now.
Great.
Yeah. Taking EP people.
Those are the people you want. So they'll be the ones who are most facile with these medications. So that's very helpful.
Flecainide affect the mom in terms of that?
I have that coming up. Okay, so this is a very small printout here, and this you don't have to memorize, but what I want you to look at is kind of this side effects area over here. One of the things that I know, you guys are probably used to seeing pregnant women feeling nausea and vomiting every day, right? So what you have to remember, though, when you're starting these medications is that can be a side effect of the drugs. So when you're seeing that, you really want to have a very low threshold for checking a level of your medication and considering that as the etiology of the nausea and vomiting rather than pregnancy. Yes?
Would you mind sending us this slide so that we can put this for our pockets?
Not at all.
Are we going to get the whole slide set?
I can certainly send you the whole talk, but we also have the doses and everything on there too. But we can do this too. Or there may not be all of the medications. I can certainly send this to you. The other thing, amiodarone, which we don't commonly use, but is not on these protocols, but sometimes we get to that, can also cause hypothyroidism, so it's good to have a screening thyroid panel prior to starting it and then during therapy as well. So let's talk about those medications briefly. So starting with digoxin, there's about a 50% conversion rate with SVT. Compared to the other options that has relatively low toxicity, you want to look for fetal or maternal PVCs, heart block, or ventricular arrhythmias with DISH. So is it easy for you guys to have the mothers on telemetry during this initiation as well? Great. Okay. So the maternal trough, usually about 1.8 to 2.2. You don't always have to check that unless you're having, again, those vision changes, nausea, vomiting. And you also want to look, we don't tend to see as much EKG changes with the initiation of digoxin, but certainly if you were seeing PVCs, heart block, a QRS duration greater than 180 milliseconds, or a PR interval of greater than 200, which would mean that you pushed mom from sinus into first-degree heart block, which is not necessarily a horrible thing, but certainly warrants monitoring.
And it's any PVCs or more than 4, more than 6, or is it just?
Well, again, it's kind of a risk-benefit thing. It's certainly if you're seeing runs of PVCs, which is called VT, that would be a concern. Would be unlikely that you would see that. So, all of us probably have a few PVCs. That's why it's nice to have mom know what her rhythm is, have a baseline ECG before you start these medications, so you know what you're dealing with prior to. Flecainide is, again, the first line for SVT with high drops. It is pro-arrhythmic, so you want to monitor the fetus and the mother's heart rhythms. You want to get a maternal ECG daily for the first 3 days. On there, you're looking for your QT prolongation, greater than 500 milliseconds, or QRS prolongation as well. Maternal levels are usually drawn about 72 hours after the first dose. With your goal of 0.8 to 1. Now that you've told me you have a nice, handy electrophysiologist to help you with your QTs, then I won't belabor the point of how you measure a QT interval. But just remembering that your QT interval is really the sign of your repolarization, your depolarization and repolarization of your ventricles. And this shows a prolonged QT here. But you don't have to worry about measuring that and getting out your calipers, so that's good. Okay, so Sotalol.
Before you go on,
Yes.
on the fleckenite,
Mhm.
the turnaround time to get the level though.
I think it's about 4 or 5 days.
Yeah.
Yes.
So often when we use flecainide, we don't even worry about the level. We treat for effect. And there are standard doses. I haven't used it for a while, but
They're on the paper. Yeah, they're on the
so
yeah.
so you have the opportunity to push the dose of medicine up a little bit without worrying about the level, as long as they're not having symptoms. I think the other important thing to point out is that some people will have symptoms with DIGE, nausea, seeing the green lights around, rings around lights, before their level is 2. So really, you need to treat the patient, not the level, right? So the level can help us if we're concerned about toxicity, but while we're waiting for the level to come back, we should be holding the DIGE dose if we're concerned, or the same for flecainide, right?
Sure.
We wouldn't want to continue to treat somebody who's symptomatic, just pending the level.
I agree. Okay, Sotalol is, again, better for flutter than for SVT. The conversion rate for flutter is about 65%. This is, again, proarrhythmic, and so we're, again, maternal ECGs for the 3 days when you're starting the therapy in the hospital, something to monitor there. Atrial flutter. So flutter is an atrial rate usually 250 to 500 with fixed or variable conduction. It's usually 2-to-1 or 3-to-1 conduction to the ventricles. The onset and cessation is abrupt, and it's associated with high drops in a wide variety of numbers here when you look at these studies. So this one we had seen previously with a fast atrial rate and a 2-to-1 conduction to the ventricles. This is the fetal atrial flutter protocol currently, and that should be on the other side of your handout that you got. You'll notice here that really Sotalol is option. You can, if you have high drops, obviously you don't want to start with DIGE, and Sotalol is the first option here for a hydropic baby, although you can use DIGE plus flecainide otherwise. So ectopy, looking at ectopy, so premature atrial complexes are probably our most common fetal arrhythmia that we see. They're usually clinically insignificant, although about 1% of fetuses with premature atrial complexes may have structural heart disease, and about 0.5% may develop supraventricular tachycardia. So remembering that your premature atrial beats, normally your P waves are coming from your sinus node, and then occasionally there's the bad kid in class who jumps out and steps in early, and that can result either in a conducted beat or in a non-conducted beat to the ventricles, in which case if it's non-conducted then you get usually some bradycardia, and if it's conducted then you usually get an irregular rhythm. So you can get atrial bigeminy, trigeminy, and there's really no difference in the prognosis for these babies, whether they have blocked PACs or not. It doesn't really matter. Okay, so here we see an image going through the, again, right atrium and left ventricle here. We talked about this earlier with the early atrial activation here, the premature atrial complex that is not conducted to the ventricle. Again, they are rarely associated with structural heart disease. It could also be a sign of myocarditis or intracardiac tumors or maternal caffeine or decongestants or tobacco. There's usually a benign prognosis. They usually resolve in the first few months after birth. And some, I guess the most conservative management would be weekly Doppler auscultation to screen for that SVT. I think that's probably not quite necessary. Most of the times when I see the mothers with these, I say, don't worry about it, your baby's going to be fine. And I don't know, how strict are you guys with having these mothers stop caffeine? Fairly strict.
You can say it all you want.
Yeah. I think generally it's a pretty.
Chocolate's a bigger issue.
I think it's a low. What'd you say is a bigger issue?
Chocolate.
Chocolate. Yeah. My thought is it's really not harming the fetus. It probably harms the fetus less than maternal depression. So if caffeine and chocolate make her feel better, I say let her have them. That's my thought. But. Right? Or shaken baby, or, I mean, you know, I say just give them the chocolate. Okay.
How often do you monitor them
After they're born, you know, what I usually do, it depends on the level of the comfort of the pediatrician. Often I'll just say, if you want to just listen to them, if you're hearing a lot of ectopy, then you can give me a call. If you want to, they can usually just follow them with auscultation, maybe with a baseline EKG.
What would the frequency?
I would say they don't require any additional extra monitoring than other babies. So they're usually, you know, whatever your normal protocol is in the newborn nursery for following them there, and then once they're discharged, is that more what you're thinking about? Then I would say just kind of routine pediatric follow-up. So usually babies are seen a couple days after discharge, and then kind of at 2 weeks and 2 months, and so.
So the risk for SVT would
it's pretty.
change once they're born?
The risk doesn't necessarily change. It's just that it's a very low risk, and the vast majority, so it's 99.5% won't have it. So that doesn't really warrant following all of those. So those babies who have PACs, most likely they'll resolve as the foraminal flap closes and there's kind of less activity in the atria to stimulate PACs. So I don't know, do you follow them more frequently? Would you recommend following more frequently?
I think if you had a fetus who had non-sustained SVT, so you chose not to treat the mother because the SVT was not incessant, I would teach that family how to count the heart rate. So I send them home with a stethoscope and tell them to check the heart rate once a day.
Sure, that's, yeah.
But with
so
PACs, EKG at screening, just to make sure there was no short PR interval or reason to say there's WPW and therefore risk for recurrent SVT. If their baseline EKG only shows PACs, I don't do anything with them. I tell the parents they're normal. Send them home, don't worry about it.
Because what I was sort of trying to get at indirectly is the frequency of us students.
Yeah, that's where I think that weekly, that's why I was saying that weekly recommendation that some make, I don't think is really necessary. Once you establish that it is PACs and not some sort of heart block, I think that's the first important distinction, then I think you can kind of follow them as you would routinely follow them.
And my rule of
my
thumb
personal
has been if they're going to go into SVT and it's important, we'll pick it up either when we screen them or when you guys are listening to them on their regular dot tones over their abdomen, right? If you're not picking it up either with your regular screening or during an ultrasound, then they're not having enough of it for us to treat.
So you don't see probably most of the people that we see who just have PACs, but it's not unusual to make a recommendation to auscultate the heart rate weekly, not necessarily by us. Do you think that's irrational?
I don't think it's irrational. I just, it
Is
may be assigning a little more anxiety to the family than is necessary.
It's not necessarily us that's doing it.
Right, absolutely. And I think the thing that Susan said, when we have these fetuses who have that very redundant flap valve in the foramen, you guys are seeing that, right? When that's there, we're not going to make those go away, but they're also likely not dangerous arrhythmias because we think they're associated with that redundancy of the atrial septum. So in that case, I would say weekly office auscultation is a lot of overtime.
So what if it's not picked up at all until during labor? What if you pick up no arrhythmia, so you do absolutely nothing postpartum with the baby? You just make sure they come out with good MRs, they look good clinically, the baby.
I think if you see PACs, we would still say, maybe get that screening
Well, you wouldn't
EKG.
know necessarily if they're in labor. I mean,
Well,
you
if you
would
get it in
know
labor.
if they're PVC.
Wouldn't it be benign enough to just get an EKG on the baby after delivery?
Yeah, I think that's
Yes.
what Susan
Is that what you're? Yes.
Okay. You mean, so go ahead and give it an EKG on
Like
the
she
baby.
said.
After they're
Okay.
yeah,
Okay.
out.
So if you hear something in labor.
Sure. Yeah. I think it'd be I don't know, I guess, does your arrhythmia of PACs increase during labor? It seems like it'd be unlikely that you'd find yourself in that situation, but if you do, just get an ECG.
Particularly in totally normal pregnancy.
Because they're listening to them for a long period of time.
Oh,
not just-
okay. I see what you're saying. So you haven't picked it up on your screening previously
Right,
yet.
but they're not
Not that they've
necessarily
just developed.
getting
I wouldn't do
ultrasounds.
anything different.
Yeah.
No.
So you would
I mean,
measure-
I've heard it several times,
Yes.
that from the WIU and, you know.
It's just like if you put a Holter monitor on all of us, right, we probably have some PACs. So,
Well, there's a lot of vagal stimulation during labor, right? So it, you know, it's probably not surprising. And also you're getting the perfect therapy for risk of SVT, right? You do vagal maneuvers.
So when you see them, you just say
It's a
push.
therapeutic intervention in the labor.
you need the baby to push, not really mom. Okay. So PVCs are very, pretty rare that we see those. Oh, I'm
I
sorry.
just wanna follow up on that.
Yeah.
How good is that for protecting,
Vagal maneuvers,
I
that's,
mean, in terms of labor and vagal activity?
well, I can't honestly say I've ever heard of or experienced a fetus converting during labor. On the other hand, that is how we have parents terminate arrhythmias for their newborn babies.
Yeah.
We have them flip them upside down, hold them up by their feet, just like you guys used to do in the movies.
Spank them.
Make them cry, hold their breath, right? I mean, that's, so it should work. Whether it would, I don't know. Because usually by then, if they're in SVT, we're all delivering by C-section rather than putting them on.
Not necessarily.
We'll try it sometime.
No.
Let's change face, like, no.
Well, no, I mean, it depends if you can read through the SVT. I mean, if you can't read through it, there's.
Well, that's the challenge with
fetal
heart
well-being,
block.
they're getting
Yeah,
sectioned.
that's your challenge with heart block as well, right? You can't monitor fetal well-being, so likelihood of a section is much higher.
Although typically, just as a blanket statement, there's not necessarily, unless there's some other concerns about fetal well-being, just the presence of an arrhythmia doesn't prohibit vaginal delivery. PVCs, or premature ventricular complexes, less commonly seen, more likely to be associated with myocarditis or some sort of a little more pathologic picture than your PACs are. So a structural screen for them is important. Okay, so speaking of fetal well-being, I'm sure you guys are all familiar with this score. Looking for the cardiovascular profile score, where 10 points is normal, and all of your normal flow patterns start over here, looking at your umbilical vein and your ductus venosus and your cardiothoracic ratio, your cardiac function, whether or not there's fusion of your inflow velocities, and then of course your umbilical arterial waveform. I'm sure you guys see this a lot, so I won't belabor this point, but we also use this, and thank you for this development. That was helpful. So early changes in that score can be seen prior to the onset of hydrops, right? So when we start seeing that impaired diastolic filling of the ventricles, that usually occurs before we actually see the hydropic development. And so it can be useful to not only evaluate the fetus in the first place, but also for serial monitoring of the fetus. Okay, so after delivery, again, you guys have succeeded, gotten the baby to delivery. So then the next step, kind of what we and the pediatricians do, and the information you can pass along to them, is that fetuses with difficult to control arrhythmias in utero may become infants with difficult to control arrhythmias. So what we don't want to do is have the baby, after the mom has been treated with Sotalol for 2 months, have the baby be born, go to the newborn nursery and not get any medications and just go home, right? So what we do want to do is communicate, to the pediatricians that this baby does need to have some monitoring after birth, needs to have a baseline EKG after birth, and may need initiation of medical therapy after birth. Now, babies with flutter often will, once we get them out of it, will often stay out of it, but those babies with SVT may have recurrence more frequently than them. So often we need to transition that infant to antiarrhythmic therapy. The good news is just because the mom had to get Sotalol doesn't mean the baby is necessarily going to need Sotalol. So once again, on that risk-benefit ratio curve, we're going to back down and think about something more like DIG or Pranolol for those babies. Questions or comments?
So you had a slide on the flecainide and sotalol for moms having side effects. So especially women that have chronic hypertension, one of them had a renal effect, one of them had a liver effect.
Mm-hmm.
So which one would you pick if someone's got high drops in SVT that's uncontrolled and a chronic hypertensive? If you look at the metabolism, one's hepatic, one's renal.
Yeah.
Right. The flecainide is more.
Probably I would go with the I mean, again, we would still probably not necessarily change that and probably go with the flecainide on that mom. I don't know if you guys feel
And just like
differently.
preclamatics with mildly elevated liver enzymes, would you still?
Yeah, probably with the.
I mean,
And-
question
and
is how
this is
different
where your
is it?
adult colleagues become so
Yeah.
critical to you, because they can really help you make those decisions, right? We aren't the experts in adult hypertension, renal disease, liver failure. They are.
Essentially, how much beneficial is flecainide over sotalol in hydropic infants?
Yeah, I hate slow walls, so don't ever ask me.
Okay.
I say every time.
There's a reason why it's at the bottom. Most of those, and again, it's just the risk-benefit ratio. You know, it's pretty recognized that sotalol is one of the more dangerous
More side effects,
antiarrhythmics.
gotcha.
So, you know, do you want your chronic hypertensive mom to have more arrhythmias or you know, or more risk of arrhythmias? So again, I would probably, as Dr. Sharkey says, asking your adult EP doctors who are used to dealing with hypertensive people constantly would be a good resource for you there.
So it also looks like there's really no role for dual therapy anymore.
So there
For
really
SVT.
with SVT typically not. Now, although you know sometimes things change. Again, this is a protocol as a suggested starting place, and again that can definitely be useful in some situations.
And then the other question obviously is when you have a baby that just doesn't respond to maternal therapy, at what point do you jump ship and go for in utero therapy?
Well, I think that's a good question. I thought about putting that into this talk, but I wasn't sure if that would be. You know, again, it's all about that balance of risk of preterm delivery. Now, you guys are the ones who would have to do that, so you tell me how risky do you think that procedure is? Because I read about that and I just think.
That's because you don't know Zorro, Dr. Gross's alternative name.
So is Dr. Flastos. But
Yeah,
I mean,
that's true, too.
we've done the. I still remember the day we used adenosine, which must have been well over 10 years ago.
Oh, in the cord?
And I still remember Dr. Sharkey saying, the heart will stop. And you saying that to a bunch of obstetricians made our hearts race. And
The heart's gonna stop.
Don't freak out.
Don't freak out. Exactly. And,
Yeah.
And it worked.
Yeah.
It really did. But
And it is, you know, I have been at the bedside scanning a baby in SVT, not a fetus, but a baby who's born. And when you happen to be scanning at the moment that the adenosine goes in, it is scary. I agree with you. You know, that ECG is not quite as scary as looking at the absence of contractions. Yeah. So, what do you think? When do you start thinking that the risk is?
Well, I
worth
think
the benefit?
gestational age will help to predicate whether
And more
delivery
Delivery
versus
would be
in
better.
utero therapy.
and worsening of hydrops.
So one other thing, Mike, you had asked a question about high index and inflow outflow assessment. The one thing to remember about doing Doppler on fetuses is you need to be ready to adjust your sample volume in your Doppler to clean up your signal. So mitral aortic inflow outflow is very close to each other. You should use a small sample volume. If you're going to try and do simultaneous pulmonary outflow with tricuspid inflow or SVC, you need to open your sample volume wider in order to get a good signal in that situation. So there's all kinds of little dials on those machines. We actually need to use some of them.
How long will we covering stuff with snow?
Forceps.
It's same
And that's fine.
same in the adult. You will have P waves with no ventricular conduction, and it can make your heart race remarkably fast.
Not the patient's, but yours.
Your own, as you're watching, no conduction.
Okay. Thanks, guys.
Thank you. Thank you. That was very helpful.
You may just gonna save a copy of the slides over here. I'll send it out.
Oh, that's fine. Yeah, go for it.
Thank you very much.
And then it's like, oh, it's not.